Good morning. I'm Chris Herbert. I'm the Managing Director of the Joint Center for Housing Studies. I'm very happy to welcome you today to the release of our latest report, Advancing Housing and Health Equity for Older Adults, Pandemic Innovations and Policy Ideas. The pandemic had a disproportionate impact on older adults, exacerbating issues of isolation and access to care. In response, hundreds of public agencies, community groups, and other organizations developed new approaches to help provide supports and services to older adults. Today's report is intended to look at what were those innovations and what can be adopted and expanded on in meeting the long-term needs of older adults. We researched and wrote this report in partnership with colleagues at the Hastings Center, a bioethics, independent and interdisciplinary research institute that explores ethical and social issues, including those in an aging society, and with the support of the RRF Foundation for Aging. The report is available on our website. Today's event is actually the first of 4 webinars that will be hosted by the Joint Center and the Hastings Center to highlight findings from this report. On October 20th, Hastings will host a webinar on lessons from age-friendly networks and villages, and we'll host a webinar on November 18th on lessons from service-enriched housing. The final panel, hosted by Hastings on December 8th, will explore how we might change the narrative around aging, housing, and health. Information for all these events is available at our website, jchs.harvard.edu, which you probably know how to find if you're here at today's event, and thehastingscenter.org. In a moment, Jen Malinsky will share findings from the report. But after that, we will then have Nancy Berlinger moderate a panel with 3 guests who each have a different role and vantage point during the pandemic. If you have questions, please do use the Q&A feature at the bottom of your screen. We'll try to answer as many questions as we can, but as we have hundreds of people literally watching this, we won't be able to get all of our questions, so please be patient. The closed captioning is available, and a recording of the event will be available on our website after the event is over. So thank you for joining us. Thank you to the Hastings Institute and also the RF Foundation for the support. And now I'd like to turn it over to my colleague, Jen Malinsky, who will present the findings from the report. Jen? And if someone could let me know if we're showing the right screen.
You are.
All right, and here's Jen.
Thank you, Chris. Good morning, everyone. We are sharing office space today. So I'm pleased to share the results of our new report that's pictured here and is available on our website as of today. We began this work in early 2021. We'd already seen that the pandemic was acting as a stress test of the system that we have for housing and supporting older adults in the United States. And I use system loosely, but mean the collection of policies, practices, supports, and conditions that have resulted in the types of housing available to older adults today, and the challenges that result from the gaps in that system. So as we've highlighted in previous reports, in 2019, a third of older households paid more than 30% of their income for housing. Half of them paid over 50%. Over 2 million older adults face worst case housing needs, meaning they pay more than half their income in housing, live in homes that are physically severely inadequate, or both. Less than 1% of US housing is wheelchair accessible, and most of it is serious impediments to even basic accessibility. And we know that there are vast inequities by race, ethnicity, income, and between homeowners and renters. So during the pandemic, this fragile, incomplete, and often inequitable system was pushed to the limits. Rising costs and lost income increased housing instability and food insecurity, home maintenance, safety, and accessibility, which were still very much needed by older adults, were put on hold, though still, again, very much needed. Access to services, groceries, doctors' offices were disrupted, and in some cases, people lost the home aids and assistance that they had relied on for care and tasks in the home. And of course, social isolation worsened, as we know. The pandemic also highlighted the importance of housing to people's health. The CDC issuing a moratorium on eviction is a striking example of just how important public health community perceived housing to be. And the gravity of the early pandemic months also highlighted the importance of specific aspects of housing, whether that is access to green spaces and fresh air, the digital divide, which became even more prominent as more and more daily life moved online. And the pandemic really shined a light on how care and supportive services are underfunded and undervalued, and how, on top of struggling to afford housing, many also struggle to find and pay for the supports that help them stay in their homes. But the responses by government agencies, housing and service providers, advocates, civic groups, and more was remarkable. The pandemic, with all its uncertainty, constantly changing information, supply chain disruptions, and the serious risks, particularly for older adults, was a laboratory for innovation. And these actors innovated as best they could with what they had in order to make sure that older adults had what they needed: internet, technology, groceries, hot meals, ways to engage with others at a distance, safe trips to the doctor, and much more. These responses were often in the form of direct provision of supports and services to older adults. Other responses fell into the category of supporting service providers and caregivers, and still others involved administrative relief, which we call structural shifts here, that enabled responses that previously were impossible. And these were occurring at the local, the state, and the national levels. So our research involved collecting examples of these responses, what we called promising practices and policies that emerged during the pandemic, and then extracting lessons from them that might be useful for building a better and more equitable system of housing and supporting America's older adults. So to identify these, we turn to gray literature, which encompasses reports, newsletters, posters, websites, webinars, more that are outside of traditional academic writing. And we used a broad approach, from Google searches to referrals from organizations and advisors, and even a submission form on our website to identify responses, most from the US, but with the help of a handful of wonderful colleagues in Toronto. We also have examples from Canada. And this led to the creation of a database listing over 200 initiatives. And this on the screen is just a small snapshot of what our database looked like. Many of these are described in our report. And we certainly couldn't capture all of them across the country. And we know that we'll continue to hear more examples coming forward as we talk about the report release. To identify common threads among these policies and practices, we consulted with our Housing, Public Health, and Aging Network, a group of people involved in these fields. And we focused on 3 questions in particular. First, we were looking for common threads and responses. What was the secret sauce that seemed to be common among these responses, and that might allow them to be replicated in other places, even when the context and the situations were slightly unique? Second, we understand that much of what the pandemic did was to magnify things that we already knew, that quality housing is important to health, for instance, that services delivered to people where they live is often the most efficient and effective way to do things. But we tried to see if the pandemic had deepened or expanded our understanding of the important role played by homes and neighborhoods in health. And lastly, some of our findings were about barriers that frustrated response or that required extraordinary effort to circumvent. So what were those, and what might we do about them? And this led us to 6 major observations or lessons. And then from there, we developed specific recommendations for different actors, funders, and public agencies. So let me turn now to our findings and our recommendations. So the first finding is that effective responses very often came out of established networks of organizations that had been created years before to advance age-friendly goals. In Massachusetts, the state's efforts years ago to pursue age-friendly policy in an age-friendly state designation had spawned a very active network of agencies and organizations devoted in some way to health, housing, and aging services. When the pandemic hit, that network became a hub for information sharing, with grassroots organizations sharing on the ground challenges with the state level policymakers, and those at the state sharing evolving advice and policy. Organizations also traded strategies for addressing needs. Some of these involve banding together and advocating for older adults, convincing the state, for instance, in its vaccine rollout to give priority to senior housing as well as nursing homes. The relationships among networked organizations also resulted in partnerships to deliver food and healthcare, and similar things happened across the country. In New York City, where older adult leaders of age-friendly neighborhood groups met regularly to share strategies and advice. In New Jersey and Hawaii, where age-friendly organizations came together around food security. A big takeaway for me was that age-friendly efforts are useful for what they produce on the ground, so to speak, whether that's safer streets, better housing options, more volunteer opportunities for older adults, but also for the relationships that they build that can be deployed in an emergency or to advance other goals. And what made these networks so successful, they had these pre-existing relationships. They were built around a set of shared knowledge, and they had trust. A second observation was that effective responses relied on input from older adults and were designed with older adults themselves. So many organizations were very creative in reaching out to older adults to understand their needs and experiences and to share information about evolving COVID guidance or vaccines. They conducted outreach in multiple languages and formats. They relied on trusted local partners and individuals. This is particularly the case with the vaccine rollout. As we know, it could be politically fraught, but local leaders from religious communities or grassroots organizations could help convey information to older residents from people they knew and trusted. And at the same time, many older adults engaged directly as volunteers themselves. And lastly, planning efforts that were underway before the pandemic, such as California's Together We Engage effort, which is created to inform the state's master plan on aging, switched to new platforms, and they were able to expand their reach to even more older adults. So what these disparate efforts have in common is that they innovatively connected with older adults and at times caregivers, crafted responses that were informed by accurate information about needs and preferences. And again, they relied on and promoted trust between older residents and policy and program leaders. Third, we saw that effective responses in housing dedicated to older adults typically had service coordinators or other staff at their core who would connect with older adults on a one-on-one level. Coordinators then leveraged their own networks to get people what they needed. They had networks with food pantries, with health clinics, with restaurants, transportation providers. They worked with volunteers to source technology and help train residents to use it. They communicated with family when non-residents couldn't visit. In more dispersed residential settings, villages, organizations that are designed to help people remain in their communities, played similar roles, performing wellness checks, organizing vaccine campaigns, running outdoor social programming, again, leveraging resources and relationships to meet people's needs. Information was important too. These service coordinators in villages both served as trusted sources of information amid all the uncertainty. And in both cases, again, it was the existing relationship, the trust, adequate funding. There was additional funding that certainly helped that I'll talk about in a moment. And this idea that older adults could go to one trusted person or organization to be directed to other resources, a no wrong door approach. A fourth lesson that falls more into this category of things we already knew, but were really emphasized by the pandemic, was the importance of physical design and accessibility of home and neighborhoods. So many older adults living in high rises could not get safely outside without using common elevators and hallways, which many people did not want to do, or even get to the lobby of their apartments to receive a grocery or a pharmacy delivery. Some of those latter issues were solved by volunteers and neighborly support, but the former was trickier, particularly in buildings without balconies or operable windows. So a lesson I think we might take from this is that even in affordable housing, that designing for safety and health and community is possible, that these are not luxuries. And there are some wonderful design guidelines that we mentioned in the report that emerged from the pandemic and that we hope will inform renovations and new housing going forward. Outside the home, issues of inaccessibility in the built environment and inequity in the provision of green spaces were certainly issues and continue to be. A second observation underscored by the pandemic is that access to the internet is critical. In today's world, it is pretty much a basic utility and should be treated as such, and that's why we put it here in this part of the presentation. And lastly, the pandemic highlighted the ongoing persistent need for accessibility modifications in home maintenance. Organizations like Capable and Habitat for Humanity developed new protocols to carry on their work, but the need for physical distancing certainly slowed progress and has added to the backlog of need. So coming out of the pandemic, we need these programs more than ever. In some ways, the pandemic was a case study in what regulatory flexibility and better funding could do. Simple steps like allowing digital signatures on documents freed up time and let programs run more efficiently. Temporary changes to regulations around insurance reimbursement for telehealth gave millions access to doctors when the alternative might have been not to see a doctor at all. When home health aides could no longer attend people and families stepped in, more states permitted payment to family caregivers under Medicaid. And emergency funding helped expand benefits, such as for SNAP and emergency rental assistance. And of course, the eviction moratoria helped keep people in their homes. The urgency of the pandemic created the political will and showed what was possible, which I hope is a lesson for all of us going forward. And finally, we come to an observation about persistent barriers. The pandemic really showed the importance of linking services to where people live and the fact that many need supports and services to remain in their communities. But housing, service, and healthcare programs are not as well coordinated as they might be. Eligibility for rental assistance does not make one eligible for home-based services, for example. And this poses challenges for older adults and for the housing providers trying to support them. Policies around care are often disconnected. And when care occurs in the private home or by a family member, it is typically undersupported. Meanwhile, the paid workforce, of course, faces its own challenges, including earning enough to pay for their own safe and stable housing. For government agencies, nonprofits, for academic research groups, trying to figure out what interventions work best, the disconnect in the data between health and housing is a sizable constraint. So where do we go from here? For the long term and for what we call the next predictable emergency, because certainly there will be predictable emergencies, we recommend a number of steps in the report. I won't go into detail now, but these involve nurturing networks, helping to establish these important relationships, share knowledge and trust before an emergency, improving outreach to support and support of older adults. I think we've learned a lot about how to engage with people and how outreach can inform program design and planning, and also how we might support leadership development and ongoing sustaining support for those local organizations that played such critical roles. We've learned a lot about supporting service coordination and publicly assisted housing, and I think we would call for greater funding of this important service. It is not universally available, and many do not have stable funding to provide it. And we need to learn more about how some of the benefits from service coordination can be transferred to those living in more dispersed settings, building on lessons that the villages also showed us. Certainly valuing inclusive and healthy design and inclusive design processes, including those that include those with cognitive difficulties and their caregivers. We need more study of what administrative flexibility we might keep and to use the pandemic experience to show us what is possible with more funding. And finally, we need to better integrate our housing, health, and supportive service programs, including promoting coordination among these domains, working together as professionals, aligning incentives and eligibility criteria, and improving data alignment and data sharing. So I just want to end with, on this note, to do this, I think particularly that last recommendation, we need to center home and community in our narrative around aging in place. The pandemic was a public health emergency, and most saw it through this lens, the lens of a public health emergency. Aging is often seen through a medical lens, but we want to ask in this report, and the approach we took in this report is to ask, what if we changed our perspective and thought about where people live as a starting point in our efforts to develop programs and policies? This would bring into clearer focus the inequities in housing and neighborhoods and access to technology that drive more and more of our health interventions. And so our last recommendation is to think about the lens through which we work and what might be possible if we begin with the place where people spend most of their time, that plays such a significant role in financial security, that has so much to do with well-being and living a good life. So we call this a housing lens, and we invite you to think about its possibilities. I want to end by acknowledging and thanking my co-authors on this report, Nancy Berlinger, who I will turn over to in just a moment, and Bailey Hu, who is here today and will help answer questions. And I also want to thank our Housing, Aging, and Public Health Network, who advised the study, and the many, many people who contributed their time and shared information and interviews with us. So thank you. And with that, I will turn over to Nancy.
Thank you, Jen. I'm so delighted to be here with everyone today. And I've been a researcher for a long time, and this was one of the I learned more from this experience than I have from many, many others. It's just so exciting. And it's really exciting to be at the start, now that we've released this report, of this new phase of our research, which is social engagement and public engagement through these webinars, through the report, and so on. So I encourage you, we'll get to as many questions as we can at the end, but we see all of the questions and we will respond as we can during the time available, but there will also be possibilities for engagement at the other webinars. So there is a registration link for the rest of the series. So I am now delighted to introduce our panelists who will, as I mention their names, I'll just be asking them to turn on their cameras so you can see everybody. Robin Lipson is Deputy Secretary of State for the Massachusetts Executive Office of Elder Affairs. Tam Perry is Associate Professor in the School of Social Work at Wayne State University. And Lauren Taylor is Assistant Professor at the Grossman School of Medicine at New York University. Thank you all. It's wonderful, wonderful to see you. And so Tam, if you can just turn your camera on and we'll be off to the races. So our first question is, I'm going to ask Tam and Robin the same question, looking at the local level and looking at the state level. And I'll ask Robin first and then Tam. So let's start by taking yourselves back to spring 2020, to the state of Massachusetts and the city of Detroit, because the initial COVID surge hit both of these places around the same time. Robin, what were the immediate challenges facing older adults sheltering at home in Massachusetts? And how did you and your colleagues activate a state-level response to community-level needs outside the hospital? Because a lot of the story at the time was about hospitals and healthcare settings. But we've been focusing on the home and the place where a lot of people were, and especially older people, the most vulnerable group to this virus. So what was that like from your vantage point?
Thanks, Nancy, and good morning, everyone. Let me just first say, it's wonderful to see so many people participating this morning, many people we have worked with over the last many years. So it's great to see all your names here on the board and that you're with us. So I was reflecting on this a bit last night and recalled how incredibly challenging is not even the right word, stressful, concerning this all was as we thought about how to keep people safe. And to give you some perspective, so this state agency that I work in is responsible for supporting people, older adults who live in the community. So we serve over 65,000 older adults by supporting them in their homes with home care and other services. And many of those adults are at a nursing home level of care. And then we're also the agency that regulates assisted living facilities in Massachusetts, and we serve about another 20,000 people living in those facilities. So our first thought and kind of our hunch and hypothesis, and remember, we didn't know a ton in March of 20, was that being at home was a protective factor, and that by all means, we should do everything we could do to keep people at home. And for many people, that meant getting services to them every day. You know, we have people living at homes who were two-person assist to be transferred, or who needed help to toilet and bathe and to get food and to ambulate. So our first priority had to be to maintain those services. And we did a number of things very quickly. And honestly, at the time, I don't think we were 100% sure we were doing everything the right way, but we just did it. And what we did is we took a hard look at everything we did. And the first thing we did was, where it was possible to preserve some flexibility, to not have a worker enter the home for an unnecessary reason, like to get a signature, we basically said, okay, wet signatures made sense. And this is, you know, my bad joke. It made sense for the Bill of Rights and the Declaration of Independence, but we didn't have options. But I'm not sure I needed to send a worker out just to get someone's signature when you could talk to somebody on the phone and document that they consented. So we tried to eliminate visits that weren't adding personal care, that weren't touching people, that weren't bringing services into the home. so that we could then focus all of our efforts on how to provide those services safely and to best use and deploy the workers that we had. So that was kind of the first thing we did. We revamped a lot of our policies so that we could use electronic and telephonic interventions, so that we could help support people, even with things like electronic pets. You know, we just look to support folks in other ways where we could, so that we could preserve the human to human interaction for the things that could only be done by humans. And then we spent a lot of time with the workforce so that they could understand how to be safe. You know, this is before we understood all the benefits of masking. It was before we had masks on every street corner. And we worked with some local educational systems, in fact, the University of Massachusetts system, to work with their occupational health people to understand, okay, if you can't get your hands on a mask, what can you do? How do you make a mask? How often do you have to change a mask? I mean, these were conversations we were having in March of that year that really turned out to be important to worker safety and to consumer safety. So we spent a lot of time on safety, a lot of time on sharing information with home care agencies, with AAAs, with our aging service access sites. So those are some of the things that when I think back to the early days, we spent an enormous amount of time on, and they really mattered. Our mortality rate for people who were getting in-home services was infinitesimal. And so we're really, really proud of that work.
Thank you so much, Robin. Tam, how about in Detroit? You work with a housing coalition in Detroit, as well as doing extensive research. You're involved with the city of Detroit, the state of Michigan. How did things unfold there in that COVID moment?
Yeah, I think our work it really builds on what Jen was talking about having an established network. So we have a coalition called Senior Housing Preservation Detroit, and we had been working together since 2013. And we formed because we were trying to work on raising awareness and preserving low-income senior housing amidst pressures of gentrification. But then we clearly had to pivot. So it was a pivotal moment in our coalition's, history, but obviously, we had to switch to actually life and well-being for this health crisis and the lockdowns. And I would also say in the early days, for those of you who remember the news, Detroit and New York City were often in the news in the early days. We lost a lot of older adults in the city of Detroit in the first 3 months of the pandemic. So it was just profound. So we were starting to ask our coalition members, are people we're worried about able to get fresh food, protective devices, pharmaceutical supplies, like their medications, et cetera? Are they able to actually communicate their needs with other agencies? And so what we also realized, and I think nationally and internationally, there was so much press about nursing homes, that people living in senior buildings, there wasn't really a plan for them. It's kind of like independent living. So some of the regulations didn't apply. So we kind of looked at what our state was issuing as far as regulations, and really were trying to figure out where it applied and didn't apply. So things we did as a coalition, I think the other important thing to note is that the city of Detroit does not have a senior citizens department. So our coalition basically served as one, which was very, very active. So we started our monthly meetings. We went to weekly. We started really thinking about food security networks. We were thinking about, people using public transport, and was it safe or not? And so we advocated for things to be brought to senior buildings. So later we advocated for testing to be brought to senior buildings instead of people going out to testing sites. Later we advocated for vaccines to be distributed at senior buildings. And then the last thing is we really looked at sort of things, something very specific, but actually we tried to contribute. We did a panel with the city of Detroit about how do you do renovations in senior buildings? Sometimes these renovations were in progress, and then the pandemic hit. Sometimes people needed to renovate, But the idea with the renovations were there were all these extra people coming into the buildings in addition to the staff. And so there was so much concern about who are these extra people and what are the protocols for extra people coming to the, and how do they sign in and their own wellness status. So I think the last thing I'll say is we really also started paying attention to the staff well-being, that they were serving older adults and then going home to their own families and very worried about all the contact between. And so we really tried to create a forum to have solutions and also sort of make sure it was on the table, the well-being of staff.
Thank you, Tam. Now let's bring in our health policy scholar, Lauren Taylor, and remind us what we knew pre-pandemic about the relationship between housing and health, and how much we knew or didn't know about the dimension of the older adult. You've studied this topic, you've written about it for the Hastings Center, for the Robert Wood Johnson Foundation. Just a précis on this very, very big topic.
Thanks, Nancy. So I would say we've long known health and housing are interdependent, right? And the way the health policy and health services research literature tends to operationalize the relationship is to say housing has a huge amount of influence both on your health status and your healthcare costs. But the health policy community tends to be somewhat short-sighted about what goes into housing and what we mean by housing. It's just not their area of expertise. So this is part of what I really love about what you and Jen and the authors have done here in terms of the housing lens. You've helped bring to light just how complex, quote unquote, housing is, right? It's treated as like a one word, oh, when you're thinking about all the non-medical determinants of health, well, you've got transportation, you've got food, and you've got housing, and it's just one in a list. And then when you really dig in and you read this report and others, you think, oh, it's so complicated. That said, the way that I have typically conceptualized how housing influences health is along 4 lines. One is your housing stability influences your health, and we have really good evidence on that. There's been a lot of work there was a question in the chat that I saw about people who are unhoused. There's been a lot of research on the value to the healthcare system in particular of getting someone who is unhoused into housing, often with supportive services. And that's probably because those people tend to be very high cost from a healthcare perspective. And so there's a lot of priority and incentive to address people who are unhoused. And so there's a lot of work in that area. The other axes are, healthcare quality. Housing quality influences health outcomes. Much less research, but something that came through in the report as well when you think about the accessibility, or is the heat turned on, or is there broadband available? And then the third and fourth are affordability, and this is so important for seniors. So many people, I think, misperceive Medicare as like a gold card. And you think, oh, if someone's a senior citizen in the US, like they must be getting everything for free because they're on Medicare. Medicare comes with a ton of costs, and particularly prescription drug costs. And so it is very reasonable to think that most seniors are potentially in a position of having to make difficult choices about, do I want to pay for housing or do I want to be paying for prescription drugs? There's not a ton of research really granularly tracking how those people make those decisions, but it's kind of commonly accepted that we know there's a very difficult trade-off that many seniors face. And then the last kind of axis is around neighborhood safety, accessibility, sidewalks, are places wheelchair friendly, et cetera. But I would say overall, Nancy, although housing is widely recognized as a key input or determinant of health, it's very interesting. Older Americans have not been the focus by any means. And so I think there's actually quite a gap in terms of our understanding. The last thing I'll say on this is it's kind of peculiar because there is a fabulous program in PACE, right? Apologies for a screaming child in the background. But the PACE program, the program of all-inclusive care for the elderly, is this tiny program. It's particularly for people who are dually eligible for Medicaid and Medicare, but it has long been known to be incredibly effective. People remain in their homes. They are community dwelling, but they get this really wraparound set of services from an interdisciplinary care team. I'm happy to say more about how it works, but I did read something just before jumping on that during the pandemic, PACE participants had a third of the mortality of people who were living in nursing homes. So just like another data point about the value, both of staying in the community and the potential for it. Like, we can do this. It's not impossible to support people staying in the community and provide them with fairly intensive services. The average PACE participant needs help with, I think, something like 5 activity of daily living. So these are people who really need a lot of support, but they are living in the community and they did so safely through the pandemic. That's partly we should say hats off to the PACE staff who were able to flex and be creative in how they responded. But again, I think my overwhelming feeling on this is, one, it's very, very complicated to think about all the ways in which housing influences health and all the ways that one might need to think about being responsive to people's housing needs. But it's not impossible, by any means. We have examples, and PACE is a great one that I saw someone asking, like, are there things we should just be trying to scale up or advocate for? PACE, despite all of its evidence, only enrolls something like 65,000 Americans nationwide. So to me, that's someplace where I would put a bunch of my chips to say, why are we not scaling this program up? I'll stop there. Happy to take any other questions, though.
Thank you, Lauren. And thank you for setting up the mention of the housing lens, which is an analytic tool developed with insights from our shared discipline, bioethics, the idea of what are the values at stake when we think about housing? Why is this important? Why is this meaningful? And one big insight from our research is that health or healthcare frameworks alone, which is the place we tend to put our thinking about older adults, either they should be healthy or they need healthcare, can't fully account for the importance of homes and neighborhoods to health and well-being and flourishing of older adults who, most of the process of aging, unless you are a wealthy person, is spent in or close to your home and your neighborhood for mobility issues, but also for financial issues. So we developed this housing lens, which is described in the report as a tool for policy development analysis, and just a way to nudge our thinking off of always imagining that everything happens in a hospital or a clinic. As described, we focus on issues like affordability, safety, accessibility. Is this place a good fit? A person's home may be a good fit for them, but perhaps they are aging in place in a suburb that was built without sidewalks or without public transportation. So it's now talking about giving up driving. It's much harder for this person to manage the activities of everyday life. And also focuses on the practical challenges of aging in place, drawing on quantitative findings by Jen and others that show that older Americans struggle to pay for their housing as well as for their care. For example, when we talk about increases to Medicare benefits, or we make tax adjustments for older adults, we're not insulating people from the costs of their housing. The fact that you may own the apartment where you live, but the maintenance in your building went up tremendously, or that the broadband cost is more than you can afford. Many, many different things affect your budget, which is usually limited for an older American. And, the housing lens, I think, is a reminder that healthcare utilization is not the only measure of health for older Americans, or a good way to spend your money. I've learned a lot from Lauren's example of the wrong pocket problem. The idea is, if you want to solve a housing problem, your arguments have to make sense to people who build housing. So if you say, well, X saves the healthcare system money, that doesn't necessarily put money in the pocket of a developer. So we have to figure out how to have a broader conversation about what gets housing zoned and planned and built and embraced as part of communities. So I'd love to ask, as Lauren, as a health policy scholar who's working at intersections of health and other domains, and Robin as a policymaker, how does this idea of this broader lens resonate for you in imagining conversations about aging and health?
Well, it resonates 120% for me. It always made sense to me before the pandemic that we needed a tighter link. And one of the frustrations was, let's just take a senior housing building. You might have 200 older adults living there. They might among them have dozens and dozens of different health plans and people. Even if they have a case manager or someone who's working with them, there might be dozens of organizations in that building, and they don't talk to each other. And what became, so that was a challenge before the pandemic, and something that we wanted to work on, because we know the value of site-based services. We know how much it matters to have an exercise program in a building, to have a wellness nurse in a building, to have someone in a building who, the term we use here is a resident service coordinator, who can help connect people with services. You know, how do you get transportation? If you're food insecure, how do you get food? Can you have meals in the building? So we knew the value of that before the pandemic. And then the pandemic came, and that value, you know, if we were trading, if we were on the markets, that value went through the roof, right? The ability to deploy services at a site level, to share information at a site level. So we very quickly realized a couple of things. One of the earliest clusters we had in community of COVID cases was in an affordable senior building. And that director of that program came to us and said, I need to limit the numbers of transmission vectors coming into this building. So you may be sending 38 agencies in here with 122 people serving individual residents, and I need that number to be smaller. I need to have all the same workers in the building serving all of my residents. So that was one insight we had instantly, was if you could reduce the numbers of vectors, the numbers of workers, and have one worker work in a building and serve a whole lot of clients, instead of working in his or her own little orbit for the agency they work for, traveling everywhere, that was everybody's health benefit. So that was one thing we did immediately. The other insight we had is that people who were running buildings should really be on the front lines in terms of having information. And so we very quickly organized them, worked through a couple of the large housing organizations in Massachusetts, and we started to have weekly calls with people who operated senior housing to share all kinds of information, from infection control to where you get tests to eventually how you deploy a vaccine clinic. So they became very trusted partners in this work. And kind of at the end of the kind of first phase of the pandemic, when we got to vaccines, we had worked with them so that they could deploy over 1,000 clinics in their buildings in 2/3 of the towns of Massachusetts. So we really began to use housing as a community hub because those clinics often gave shots to people who were just living around the corner. So some really important insights for this health policy wonk about the importance of everything Lauren Taylor shared, the importance of housing and human services, and how all those things really have to come together. So the housing lens for me is now a rock and how I look at the world.
That is deeply gratifying to hear, because throughout this project, Robin has really been our reality test for what works for a policymaker. And so I really appreciate that. Lauren, what about you? You're a policy scholar. How does this help you out, or would this help you engage people who are used to thinking about healthcare utilization as the right metric?
I think it does, but I'll say it certainly recenters the conversation, I think, in a really helpful way. And so that's like a very helpful intervention on the conversation. Where I was sitting down this morning thinking, like, in what ways do I think we're still going to struggle to make the case about the value of housing for older Americans? It's in trying to figure out how to measure the value. And I say that because standard ways of measuring value, where I come from, I sit in a medical school all day, are generally you get more life years out of something. You get more working productivity, right? People stay at work longer and they contribute to the economy more. And so we determine that, like, whatever the intervention was that gets us that is worth it. That's a good thing. Or we get lower healthcare costs. And when you're starting with a population who is older and potentially frailer, living with some chronic illnesses, achieving any of those three is tough. And so I think we not only need to center housing and appreciate the kind of complexity of housing, which I think the report and your work generally does really effectively, but we also need to just think differently about the value proposition. And of course, we could think qualitatively about the value, but generally for policymakers, and I love Robin's response to this, like at some point we have to be able to translate it to some kind of metric. And I think it's not immediately obvious to me what that metric can or should be.
Oh, thank you. Yeah, Lauren, that is, it's really, I often have these questions, in work that I do broadly on bioethics for aging societies. So some of it's on housing and some of it's on other areas. And this question of meaningful metrics comes up a lot. People struggle with low bar metrics, or the ones that you've talked about, like how do you measure restoration of function in people who are suffering deteriorating health? Or what if you can't prove that something prevented somebody from falling, even though if you design for accessibility, you very probably did that. So I think that's a really interesting question. There's been some great questions in the Q&A about what are other areas that we need research on. And one of the things that Jen and I talk about a lot, and also Lauren, as the fact that health policy researchers and housing policy researchers tend to be socialized differently, looking at different data, getting appointed in different faculties, and we need to hang out together more. There's a wonderful report that we cite in our report from Brookings about what makes housing health collaborations work, and it really starts with people building trust, sharing data, and only then enabling to build partnerships. But you can't skip those other steps of mutual learning and understanding. Well, I work with the Medicare data. Well, I work with the mortgage data. Here's why this is important. So I think that is very important if there's anybody who is involved in research funding to think about how people can collaborate in research networks such as the one we have, and in broader studies, so that we can actually share what we know and come up with better metrics. When we think about how important housing is to anyone and how difficult it is to be unhoused, we intrinsically know it's important, but it's difficult when we break it down using the metrics we have, or metrics that were never designed to talk about housing. So, moving along to some other sets of challenges, I'd love to go back to the now of the moment we face. And we have a national shortage of affordable housing. It's all over the papers. It affects people of every different age. It's not just an issue of affordability for older adults at all. Only a tiny fraction of our housing stock is accessible. And we don't, apparently, according to a recent very interesting report, we don't build starter homes anymore. So we don't build these small scale affordable homes that were built in the post-war era. So we compound that by sometimes land use requirements to say you can't build on such a small plot, or you can't have multi-use housing and things like that. So we've got a lot of local problems where we've preserved the character of a bygone era, and we wind up with misalignments with our population today, economically and also in terms of their age. So, going back to this idea of what gets policymakers to focus on housing equity for older adults and for other populations, because almost anything you do toward housing equity for older adults is going to be good for adults with disabilities, for example. Almost anything you do that works at affordability for one population broadens the idea that affordable housing is a community good. So, but what gets us to focus on these majority of older adults with moderate or low incomes? Because there's only a very, very small sliver of older adults who can go for lifestyle communities or buy that piece of land and move there with their friends and maybe their care robots or something like that. But there's a kind of fantasy about how we can design aging, but it doesn't match our economics and it doesn't match our housing. So I know that, Lauren, you talk with health policy staffers on Capitol Hill through different forums in DC and elsewhere. what do you think would get their attention? You know, amid all of the things that are going on, what's the kind of thing that would help them say that housing isn't just about a private responsibility, it's also a social responsibility?
My mind goes to two places. One is more researchy than the other. The researchy one is, I think, a reframe of housing stock as a public good is potentially useful. It's not a home run to get attention because we know public goods all across our society tend to be chronically underfunded. But I think that's a linguistic shift that really does what you're trying to do, which is pull it out of the domain of, oh, that's a private concern and people should be individually responsible for securing their own housing, and really puts it on the agenda conceptually as a societal issue. And importantly, a societal issue that, if provided adequately or anywhere near adequately, we could all benefit from, right? So if we're able to create an affordable supply of housing, not only for seniors, but for people generally, that creates positive flows and value, not only to the people who inhabit that housing, but also to those of us who live in community with people who inhabit that housing. So I think that shift can be potentially useful. And I've done some work, you know, using the public goods framing for other social determinants of health. And it at least kind of makes people tilt their head and kind of listen differently and say, oh, this is a different way of thinking about the problem. The second is my more like small p political self, just to go back to this idea that, you know, the pandemic unleashed incredible creativity, flexibility, relaxation of accountability standards in the policy world. And I think as an advocate, I just want to kind of catalog that, bring it to them and be like, you did it. You were able to cut through the red tape. This red tape that you told us forever and for always was there for our safety and you couldn't possibly do anything other than this. You did it. So like, what would it take to sustain these things beyond the public health emergency? In healthcare, the classic one is they told us forever, oh, we could never do telemedicine across state lines. It could never happen. You know, the licensure stuff is too hard, blah, blah, blah. You know, we get COVID and boom, everyone moves to telemedicine like in 90 days. It's unheard of. But I think that kind of, in some ways, it's positive reaffirmation of the good that policymakers were able to achieve. On the other hand, it's a little bit of shaming, like, don't go back, you know, you've done the right thing. Now let's try and hold on to that, is the second place my mind goes.
Thanks. Tam, what do you, same question. What do you think, different level, what do you think gets the attention of municipal policymakers and community-based coalitions?
Well, I guess I think one thing that's really important, both from a research and also on the ground perspective, is thinking of housing as a trajectory in people's lifetimes. So not even like their current housing, but also the impact of having to relocate on them. So we did our coalition made a relocation assessment tool that before the pandemic, but I think that for older adults, but it's the idea that like when people can't have stable housing, what happens? But as far as like in the actual sort of emergencies and on the ground, I think the pandemic highlighted so much about the need to have a coordinated plan for emergency responses. So I think one thing I wanted to point out is the uniqueness of each senior building, and that we had to definitely kind of incorporate like both the shared history and their sense of community among residents. Like, would they be looking out for each other? Is it a building that knows each other and would watch out if someone needed food delivered, et cetera? But also, you know, even an adherence to like, how does this one senior building take to rules and rule following? Because there were a lot of guidelines that came down about, you know, how people should interact and where you go in public spaces, that, you know, a better understanding of that is also important to provide tailored services. The other thing is that was fairly confusing in the pandemic was sort of whose knowledge did we trust, meaning state level, federal level, health level guidelines, and sort of how do you make sense of it and sort of support on the ground providers in understanding the regulations of who should come and how locked down buildings should be. So those are some of my thoughts.
Thanks, Tam. Now we're approaching the end of our time, so I've been weaving your questions into the questions to our panelists. So Robin, same question. What gets the attention of state policymakers in different domains? You're in aging, some people are in Medicaid programs. There's interest in the idea of using waivers to provide some support for housing costs. We've mentioned broadband access, regulations covering housing, accessibility, building codes, or greater state, federal level conversation around these issues.
So I think what gets people's attention is the reality of what is needed to support someone who chooses to live in their own home, however you define that, you know, single family dwelling, apartment, whatever, co-housing, whatever. And so there are a bunch of things that really matter. Digital equity is huge. You know, it's fine if you live in a senior building, there's someone likely there who has access to the internet and who can tell you what goes on. But boy, if you're living in a rural area, you don't have access, or you can't afford the data plan that you need that also lets you talk to your grandchildren and do a telehealth visit, that's a problem, right? So I think digital equity is huge. I think that there are very few people who age on their own in community who do not have the support of what I call an informal caregiver, a family member, a neighbor, a friend. And one of the things that COVID showed us was that those people are huge. We need to support those people, and we need to support them in a way so that they can keep their day jobs, because to Lauren's point, we don't want people to stop working. So I think support for informal or family caregivers becomes a really important piece of this equation. And I think the third thing is the availability of organizations that are trusted and that serve as connective tissue. So, you know, villages are wonderful examples. There are faith-based communities that have been wonderful examples. And so I think that promoting the ability of those organizations to kind of be responsive at a community level and to be conduits of information become really, really, really important as we move forward.
Thank you, Robin. And thank you all. Thank you, Lauren. Thank you, Tam. This has been wonderful. Thank you, Jen and Chris. It's time to wrap up, but this is only the first of our fall series of talking about housing and health equity for older adults. Our next webinar will be on October 20th. The registration link is in the chat. It will be hosted by the Hastings Center, and it will feature in-depth conversation about lessons from aging in place initiatives and networks throughout the United States, what we learned from pandemic, what we can carry going forward. So please join us. There are also going to be future webinars in November and in December. So as you can follow us via the Joint Center for Housing Studies, you can follow us via the Hastings Center, but please, we'd love to hear from you. There were questions we couldn't get to, but we will have access to your questions. So we will do our best to feed them into the future webinars. I think they're fantastic questions. You can join the conversation on Twitter with hashtag COVID-19 RECAPP, RECAPP. So I hope you enjoy the report. I hope the conversation continues in various different forums, and I wish you a good day.